I'm thrilled to invite back onto the show Dr. Nicole Lovat, and so excited about this. This is going to be our fourth interview together because this is how much we love her. Dr. Lovat is born and raised in Winnipeg, Canada. She graduated first class double honors with Bachelor of Science in both biochemistry and physics. Thereafter, she concurrently earned both her MD and PhD in pharmacology and therapeutics, specializing in insulin resistance, metabolic syndrome, and pregnancy. And we have taken a deep dive together, and now we get to keep going with some further questions today. So I was hoping, Dr. Levitt, would you mind just kind of giving us your background again, how you ended up exactly where you are, and then we will run with more of these topics.
Sure. So very serendipitously, I attended a really excellent bioidentical hormone replacement therapy training very close to the time we were going to open up our own private medical clinic here in Grand Forks, North Dakota. Initially, we had envisioned this clinic to provide direct primary care and some insurance services. But after taking the hormone training, we made a very big and sudden pivot because we knew that we had a lot of these treatment options, especially for women, that would be able to actually address their true illness rather than giving them lots of medications to mask their symptoms.
Yes, like very root cause going on here.
Mhm.
Yes.
Yes.
And for our listeners' purposes, all of this will be in the show notes, but I'm going to let you know that we have this hormone pathways and light bulb moment episode together. And that was Dr. Levitt and I's introduction to why have hormones gotten such a bad rap? Why is it not commonplace to talk about them in your doctor's office and just the whole layout? So that's a great one to start with. And then insulin resistance is always an interesting topic, and that we did insulin resistance demystified. And then also hormone optimization for brain and bone health. We took a deep dive. Can older individuals benefit from hormone replacement therapy? So again, there's some real meat in all these topics that we've already done. So we didn't want to just hit the repeat button again on that. And going to encourage you to go back, listen to those, and then come back to this episode because how we're going to lay out and reframe this is that now that patients have been on it, there are questions that come up. There are things to celebrate. There are things to go, well, now I have more to understand as any journey goes. So we're going to pick Dr. Levitt's brain here and kind of bump down through things that keep popping up on my end as I talk to clients. So one of the first things, you're in a weight loss community within our community, whether that's gaining weight or losing weight. It's just women who are really wanting to ditch the diets and have the quality of life, do the traveling when they retire, play with the grandkids on the floor, just quality
Yeah.
of life in general. That kind of goes along with this whole optimizing of hormones as well, that this really great quality life that normally means hormones need to come into place somewhere with there. But I feel like we need to reset some expectations because sometimes when people go on hormones, they feel like it's going to equal weight loss, where I'll shush in a minute and let you go. But what I've more have seen is that once they get sleeping better, once their brain fog goes away, once the hot flashes go away, all of a sudden that opens up this brain space, this mental space, the physical space to go do the workouts or get into the kitchen, the side items that lead to the weight loss. Can you talk on that for us and what
Yeah.
you witness?
Yeah. So I try to educate my patients that the hormone replacement therapy has the side effect of weight loss, which is kind of a silly way to approach. Part of my goals for going on hormone replacement therapy is to lose weight. When you go through weight loss programs that involve calorie restriction, counting macros, exercising, creating energy deficits, that also includes gastric bypass surgery and also most of how GLP-1s are prescribed in insurance. The body will have a set point in the middle of its brain that says this person needs to weigh this many pounds. It's called the hypothalamic set point, what your body thinks you should weigh. All of those other lifestyle changes I mentioned, gastric bypass, calorie restriction, exercise, they do not change the set point. So prior to having hormonal optimization, you may be in a position where you feel like you're constantly fighting your body and forcing your body to get down to a certain, often arbitrary goal weight. And then as soon as you get there, as soon as you start eating normally or rewind back some of those lifestyle changes, now you're going to rapidly regain that weight back to that set point or higher. And so the way the hormones work long term is they reduce that set point. So your body and you are working together towards that weight loss goal instead of fighting each other.
Hmm.
And for some people, it's really easy to change that set point, and other people, it's more difficult. It takes more time. So I try to tell patients to focus on some healthy dietary changes. Like every woman should be eating more protein. Everyone should be walking. And then, as you said, as those symptoms start to improve, like brain fog and insomnia and hot flashes, those lifestyle choices get easier. And then there's a desire to do things like move your body, start hobbies back up that you haven't done in a while because you have the energy for it and you're not spending all that mental energy coping with your really crappy symptoms.
Mhm. Thank you. This is so ironic that we're having this conversation today. My exact conversation yesterday with a client was about, she goes, "Do you think my body just likes this weight?" And it was interesting because all the benefits that she's getting from hormone replacement, she could tell you that her mood, like her anxiety has lifted, her depression, so in a mental spot, so much better, which has given her this mental space to go ahead and clean more. Like her house looks better. She's out walking
Yeah.
with her husband. She did do the GLP, which I want to talk with you today as well. So the anti-inflammatory piece for
Yeah.
her knees feel better. So life and quality of life, infinitely better. Scale not really budging, but clothes are feeling different. But that was her exact question is, Lindsey, do you feel like I just need to like, is this just me? And my thinking, and I would like to know your thinking, is that her body has lived at this set point also for so long that she really is seeing change and her body is shifting internally. But I think there's this settle in, and how do you tell somebody this? But you got to consistently give all these changes 6 months to a year before you're really going to start to see some of that benefit on the scale. What are your thoughts?
Yeah, there's a couple of thoughts. First, composition. I want to talk about body composition and also dosing. So, specifically in menopausal hormone replacement therapy, especially if you've gone a few years without your estrogen and you've lost bone density and muscle from a lack of testosterone, when you go on hormones, there's a recompositioning that happens. So, you're putting on lean body mass, muscle, and bone, and you're either staying the same body fat or you're burning body fat slowly because all the hormones lower insulin resistance. And so you're entering a phase where maybe you're putting on as much bone and muscle as quickly as you are losing body fat. So the scale can stay the same for months, but in fact, you've actually exchanged a dangerous visceral fat for extra muscle and bone. And the bone density, most scales do not account for that. But if you have more bone density, then by definition, you have higher bone mass. And the other factor for her or any patient is a dose issue potentially. So there's some practitioners who believe that you should use hormones for as short of a period of time at the lowest possible dose. That is based on feelings and dogma, not medical literature. The medical literature says when you want to look at outcomes, women not dying, women not breaking bones, women not getting dementia like Alzheimer's, the highest dose for the longest period of time shows the best benefit. Yet a lot of practitioners that are hormone friendly or curious will do, well, I'm going to do the lowest dose for the shortest amount of time. And that's kind of silly. That's like taking your birth control for 1 week a month and saying, well, I've limited my exposure. It doesn't really work that way.
That's a good,
Yeah.
yeah. Yes. No, that's so interesting. And do you think there's a little piece of that that a practitioner is doing that because they're like, I don't feel 100% confident in this area yet, so I'm just gonna.
Do the minimum. Yeah, potentially. Yeah.
Hmm. Yeah. Okay. So thank you. That is huge. And maybe we should talk the GLP ones with this too, because I feel like this conversation comes up a lot with the hormones. Do you offer that in your clinic, and what are your thoughts and feelings around it?
So there's emerging evidence that when women are in menopause, they lose more weight if they have a GLP-1 with their sex hormones at the same time. And that makes sense because you're using multiple medicines, the hormones and the GLP-1, that both will lower insulin resistance, which results in fat loss. The problem with using GLP-1s right away when you start hormones is your metabolism is already very slow in menopause, and you don't know what kind of fat loss results you're going to get simply by going on hormones. You could go on a good dose of the estrogen, progesterone, and testosterone and a year be at your goal weight and have none of the cost or side effects from taking a GLP-1. The problem with starting a GLP-1 in a menopausal woman is without the hormone support, you're going to lose precious muscle that you have. It's almost impossible for you to get back without being on hormones.
Yeah, that's interesting. I'm agreeing with that. And
Yeah.
do you do in-body or like what is your protocol if you were to start somebody on meds? Where's your safety point with a client to go, I feel good about this only if.
I tried to get them to take hormone replacement therapy for at least 6 months before going on that medication. And they're great medications. I use them all the time, but I feel like they are being used somewhat inappropriately in patients who have untreated menopause, untreated low testosterone in men. And you're going to get some weight loss, but a lot of that is going to be muscle, and the patient's going to be more insulin resistant when they go off that medication in a year or two, which is what most people will do eventually. And they would be in a worse position than if they'd never taken the GLP-1 at all.
Okay. And right back to, if not done correctly, like diet mentality, right? It
Mhm.
worked and it will stop when you go off.
Yep.
So, with the access that a lot of individuals have nowadays to see muscle mass, like, do you feel as long as, again, muscle mass is being monitored, proteins being monitored, like you have a good support system around your med and the talk of hormone replacement therapy, you feel like from the anti-inflammatory aspect, from the weight loss aspect, like that this can be a really good option for some patients?
Yes, and we're actually also seeing it microdosed, meaning smaller than the starting dose, just for anti-inflammatory benefits. Some people feel neurocognitive benefits, like their mental health feels better on it. They feel more mental clarity, even on top of the hormone therapy. And so
Mm.
there's a lot of areas. We're also seeing a lot of women with PCOS taking it. And we know that when women with PCOS lose body fat, they tend to ovulate. So that's kind of causing a little GLP-1 receptor agonist baby boom, with the women with PCOS getting pregnant on it.
Oh, that's good insight. Thank you.
Yeah. Yeah.
Yes.
Yeah.
Okay, and tell me if I'm wrong because I'm maybe making up this theory in my own head, but there's a piece of me that feels like this microdosing might be the answer for most because if you get just the enough benefit from the med, plus you're doing all the food piece, the fitness, I would think it would give us the least amount of scare of if I ever went off of this, I know I have all my other pieces up and running.
Correct. And in the emergency department, patients come in with, normally they're being prescribed a GLP-1 through their insurance.
Hmm.
And the caveat for insurance covered GLP-1s is most often they will require you to go to the maximum dose as quickly as possible. And that's regardless of your gender, your size, your other medical problems. And so what happens when you go to the maximum dose is you don't tolerate it, you start vomiting, you get really dehydrated, you come to the ER. Sometimes you have dehydration that needs an overnight admission or something like that, or pancreatitis or something, some complication from the medication. And these patients are going from step 1 to step 5 over the course of 3 or 4 months, 5 months. It's too fast. And so it's not the drug's fault. Just like if I gave a 100-pound 90-year-old woman 10 milligrams of morphine and she had trouble breathing, it's not the morphine's fault. It's because I gave too much.
Right, right.
Yeah.
That makes so much sense. Yes. And what I've also noticed in clients is that when there's like too much or they're not tolerating the drug well, yes, they're getting results because they're nauseous, they're not eating enough.
Yeah.
It feels good for the moment. The scale's going down, but none of our good habits are being layered in. That foundation's not happening, which is scary. My
And we
end.
know, yeah, we know that 18 to 24 months usually is when you'll stop having craving control and then you'll start to regain body fat without any lifestyle changes.
Hmm.
So
So the
it's,
med almost stops doing what it was doing.
yeah,
Okay, so and you mentioned because I used to work in gastric bypass, I worked in surgical weight loss, that we always called it a honeymoon phase and use the honeymoon phase to really layer in the lifestyle changes so that when the tool minimized, not that it stopped working, but it just didn't work as well as it did in the beginning. But I haven't
yeah,
really heard that with the GLP-1, so that's interesting.
yeah.
That's a thing.
It's, yeah. And unfortunately, some patients are being told Now you can eat whatever you want. And then they come back 18 to 24 months later saying, well, I lost all this weight, but now I'm hungry again. I'm already on the maximum dose. I'm regaining weight.
Hmm. Do you believe that there's a subset of individuals who the medication just doesn't work for?
I think that there's always going to be non-responders to every medicine. Some of those non-responders do well breaking up their dose into multiple times per week, like 2 to 3 shots instead of once a week. Or there are patients who have untreated hormone issues who it's kind of like getting blood from a stone. Their metabolism was already very low and slow. And so the GLP-1's having minimal effect.
Okay. Thank you. Huh, I always learn so much from you. Okay, so to kind of to summarize this topic here is that the lifestyle changes obviously continue to be a huge part of it. So expectations of when you go on hormones, yes, you can have internal body changes. Yes, the weight loss is part of this equation, but it's not because of the hormones initially. It's because it is setting you up for success with all these other areas of life that provide the weight loss. And you said it's a side effect. The weight loss becomes a side effect.
Yeah,
Okay, cool. Am I missing anything before we kind of leave that specific topic?
I don't think so.
All right. So, can we talk about individuals who have started HRT later? So maybe they've been past menopause for many, many years, because now I'm getting to witness my 67-year-olds start it. Have you noticed that some individuals have a harder time initially? Is there something with the rev up of this where like you can actually really go through extremes of highs, lows, and almost the opposite happening where the sleep's not getting better? It almost feels worse for a minute.
So in menopausal women, when you initiate estrogen, are you familiar with the 5 Bs of estrogen, the side effects?
Let's go through them.
Bleeding, so postmenopausal bleeding, which is benign and usually stops on its own. Blemishes, so acne. Bloating, which is temporary, like abdominal distension, it goes down. Again, it's not fat, it's just bloat. Breast tenderness, which is also transient. And the 5th B stands for mood swings, but I won't say the curse word. So those are the 5 Bs of estrogen. So you can think of those are a lot of the symptoms women get in perimenopause when their estrogen is really high before it goes to zero in menopause. So when you reinitiate menopause in women, whether it's through a patch, a pellet, a pill, if you go too high of a dose for their body, if they're more sensitive to it, they can develop more of those side effects, which feels really yucky. It feels like you're kind of on your period the whole time. Lots
Mhm.
of mood swings and if you do not give adequate progesterone with that estrogen, you can also affect the body temperature regulation and sleep.
Mhm.
So I find if you go with conservative estrogen doses and you go up slowly, most of my patients have breast tenderness at the most. And then we make sure we adequately dose their progesterone, which should ensure that they have decent sleep and good control of their hot flashes and things like that.
Okay, so interesting. So, and can you give us a time frame on what's the hang in there period with that? Because I literally just had somebody go, maybe this is just isn't for me.
Well, it depends on what their dose is. Normally, a starting dose for oral estradiol would be like 1 milligram, 1.5 milligrams at your starting dose. Some women can tolerate as high as 4 or 5 milligrams, 6 milligrams. The more they can tolerate, the better their outcome will be. But
Mhm.
sometimes you can't get them past 2. So if this lady was started on 3 right off the hop, well, that's probably too much at once, and she'd have to start at a lower dose and then slowly work herself up. I usually wait a good 60 to 90 days between dose increases, unless a lady has very severe insulin resistance and she says, I just want to get on as much estradiol as possible, as quickly as possible, and I don't care if I have side effects.
Interesting. Yeah, I think it's even helpful to just know that this is normal because I think we can hear it even in that initial consult, but then when you're living through it, you're going, oh, I
What
don't
the
like
heck?
this.
Yeah.
So, but your speak would never be, it just won't work for you. It's more of a hang in there, you will level out. Could that be 6 months to a year for somebody to level out?
So if it's too high of a dose, she could never level out. If it's like really high to have started her on it without going down, she could take it every second day or stop it and restart it at half the dose. If it's a dose problem, it might not be something she can ride out. And so normally most of my patients have very mild side effects, if any, and it goes away quickly because we go slow.
So what if, and I'm not saying this is the case, what if they are on the lowest dose and they're still getting those symptoms? You just space out the dosing, like you said?
Yeah.
Okay.
Or they just need more progesterone.
Okay. And so I think this is my people get nervous about talking to their center, right? To their physician because they're like, I feel dumb. I feel whatever it is, however we get in our own heads when we're sitting at home going, should I reach out or not? Would you say the common message should be your own advocate and ask every question that comes along the way?
Yes. And most of the hormone providers will have already heard from their patients on the most common side effects and know how to manage them very well. And so maybe her provider doesn't know she's not feeling well and she needs to tell them.
I think it's 100% that. I think, again, living in this space and now having multiple clients on it, I get the questions first. And
Yeah.
it's like, no, no, wait, we need to use that person, use your
Yeah.
provider. They're going to have your answer. So, yeah, that's good. And even to the extent I have one person and she is using her provider and he's actually continuing to research for her, but she went on testosterone, progesterone, and estradiol and had the opposite, like totally awake all night, couldn't fall asleep if she tried to. And then also the bees that you were talking about of like
Yeah.
complete mood. So he took her off of everything but testosterone and is researching for her. Have you had anybody with that specific experience?
No, I haven't. It makes me think that perhaps the estrogen dose was too high, or there's rare women who don't tolerate certain forms of estrogen, which you're talking less than 0.1% of women. But if it's you, it definitely matters. And so she might be somebody who needs a different route of administration or a different dose.
Hmm. And then uterus, no uterus. I know we've had this conversation, but I think it's worth bringing back up because this even came up in this topic. If I don't have a uterus, do I have to have the progesterone to go with the estrogen piece?
So the answer to that question is you do not need the progesterone for your uterus because you don't have a uterus anymore. But
Hmm.
progesterone protects your breasts from breast cancer. If you have ovaries still, that protects your ovaries. If you have endometriosis, it suppresses the endo that could be anywhere in your body still. You also protects your brain and your bones. And so just because you're missing a uterus doesn't mean you're missing all the other female tissues that benefit from progesterone. And so not giving women progesterone who've had a hysterectomy is basically dogma at this point. It's ignoring the rest of the systems in a woman's body that benefit from progesterone.
Fabulous. Thank you. Was there any other uterus, no uterus talk that comes up question wise for you that I'm not thinking to ask?
Well, one thing that sometimes women don't know or not is if they're in menopause because they've had a hysterectomy
Mm.
and they've left behind the ovaries. And so they're not sure, like they had a hysterectomy 15 years ago, but they don't know when their hormones stopped. And so
Mhm.
that can be a little confusing for women because they don't know exactly when they went into menopause.
And wouldn't you come back with that and start to say it's not even about that at this moment, it's about your symptoms?
Basically, yeah, at that point.
Okay.
But there is a special window that applies to synthetic hormones. So a lot of these women will have been told that they are not candidates for hormones because they're too old or they're too long since they've went through menopause, but that does not apply to the bioidentical hormones.
Yes, and thank you for saying that, which also goes along with I had a pharmacist the other day mention the half-life of hormones and how they do leave our body much more quickly, like medications. Talk on how medications can stay in our body versus something that's more bioidentical to our body.
Yeah, so a good example of a medication that lasts a really long time in the body are the osteoporosis drugs, the bisphosphonates. They can have half-lives of decades. So a half-life of a drug is the time it takes for 50% of it to get degraded or metabolized. So decades means it's in your body forever because by the time two half-lives go by, you're not alive anymore. Other drugs like T3, which is active thyroid, have a half-life of a few hours. So the rule is five half-lives is the time it takes to get out of your body completely. So you're talking like 24 hours for T3 to get out of your body.
How many hours for an estradiol?
Estradiol, I don't know off the top of my head.
Okay. Do you know progesterone or testosterone?
I have them written down somewhere, but I haven't looked at those in a while.
No
Yeah,
worries. Calling you out. Can I promise our listeners could we circle back to it and I could shout
sure.
it out in a newsletter type of a thing?
Yeah, sure.
Okay. I
The
was
gist
just
of it is that basically the bioidentical hormones have very short half-lives. And so they're out of your body very quickly if you want them out of your body.
yes, because that was making a lot of sense to me as somebody saying, "Oh, I don't like these five Bs that are happening to me, that I hate the fluctuation of mood and whatnot." And there's this comfort of if you try it and you really can't stand it and the dosing doesn't matter, blah, blah, like it does leave your body, right? There
Right.
is nothing that somebody's going to go on with a bioidentical hormone that they're just stuck with, correct?
Correct.
Okay. And even the T3, like if people are doing the desiccated thyroid piece of this, you know how regular thyroid medications, like once you start them, I feel like you kind of have to stay on them or else your thyroid stops. Is this correct that your thyroid kind of stops doing its own function?
So all of the like thyroid hormone and all other hormones that we've talked about today are have a feedback loop. So the
Mhm.
brain produces hormones that dictate what the thyroid gland produces. So when you take external thyroid, whether it's synthetic T4 or synthroid, or it's a combination with T3, it suppresses the TSH, which is going to lower production of thyroid hormone. If you stop those medications, your thyroid goes back to what it was making before. There's no permanent damage to the thyroid gland. It's just temporary suppression. And so whether it's synthroid or desiccated, if you're not on it for actual, your thyroid gland has been removed or destroyed, you can always try going off of it as long as you have some thyroid function left. But if your thyroid gland has been completely removed or completely irradiated, destroyed, then you do not have any thyroid tissue. You are dependent on some form of thyroid replacement for life, or you go into a coma and die.
Okay, that makes total sense. But
Yeah.
I think there's been a scare into the other realm of where people are using it just for a boost
Yeah.
and feeling like I could never go off of this or else my thyroid has stopped functioning on its own. So,
Yeah, those patients, when they go off, they're using desiccated thyroid for off-label reasons like cold intolerance, fatigue, symptoms of
yeah.
hypothyroidism, but they don't
Hmm.
actually have a thyroid gland failure yet.
Hmm.
Then they do feel a lot better. And then when they go off, they'll feel like they felt before. So the benefit's going to go away without taking it, but it's not damaged their thyroid gland.
Thank you for layering that in. I'm just as much comfort as we can give people as possible, and you're doing
Yeah.
such a beautiful job. So, oh, you're gonna like this one. Okay. We need your expertise around the whole, once people are on hormones, these conversations, these looks that are happening from our other physicians, providers, as we're going into their office. And I will give you a prime example of one of my clients goes into her gynecologist. And luckily, she herself has listened to 1,000 podcasts and she felt very comfortable with what she had said yes to. But while in that physician's visit, was told that her testosterone was dangerous, was told that she didn't need to be taking what she was taking, and even for somebody that confident of what she was doing, walked out kind of terrified. And in my head, I thought the common person has no fighting chance of feeling confident if this is the exiting scene of this person who is on top of it. So I'm like, I could just dump that in your court for a minute and see where you go with it.
I find it kind of sad. It's almost like an abusive relationship that patients have with their PCPs, the OBGYNs, or their doctor that looks after X or Y. I'm sure that friend of yours had gone to her OBGYN asking for help for probably a number of years. I'm having hot flashes. I feel like strangling my husband. I can't sleep. And the OBGYN has been taught and trained over the last several decades to say, I'm sorry that you're a woman of that certain age. Here's a psychiatric medication. Here's a hysterectomy to get rid of that pesky uterus. Here's all these interventions. And that patient went out and found hormone therapy and has a good quality of life because of that. And then returns to her OBGYN, and that doctor still has the power to make her doubt her own choices. After years of gaslighting and years of dismissing her concerns, she still trusts that doctor enough to think, oh, maybe I'm doing something wrong,
Yeah.
which is an interesting psychology. I'm hoping that as more and more patients feel educated and empowered, they'll start questioning, why do I care what my OBGYN has to say? after they dismissed me for 10 or 15 years. If they could have helped me, why didn't they? If they could have helped me and they didn't help me, well, then I'm even more upset because they had the tools. Oh, they didn't have the tools. Well, then why are they questioning when I found somebody who had the tools to help me? And I try to make this analogy in that if you have an electrical problem, would you go to a plumber and ask them to fix it, or would you find an electrician? So I'm an electrician and I do hormone therapy. The OBGYN is a plumber and she'll cut out uteruses and give people psych drugs for hormone problems, and I'll give them hormones. So if you go to the wrong tradesperson with a problem that isn't their area of expertise, you're going to get a non-expert answer.
Hmm. Oh, yes, you nailed it. I mean, literally, she has walked out with an anti-anxiety med, with birth control, with anything but just
Yeah.
masking. Yeah.
Yeah.
Which also brings up the question, because I had somebody else start to mention this, that, well, okay, let's go here first. So for the provider who's dabbled a bit, like they kind of are starting to understand the hormone replacement therapy. But so some of the clients I feel like are getting put on things, but we're not sure if they're the right things, or it's the thing that's
Yeah.
covered by insurance, but is it like here comes a whole nother confusing section. What are the questions that people need to be asking to make sure that they're getting on the things that are going to benefit them the most?
Since the FDA has been changing commercially available either synthetic or bioidentical, most of the patients are going to get low dose estradiol patches, which won't help protect them very much at all. It might help a little bit of their symptoms, but it's not going to be enough of a level to get anything good done other than symptom control. Or they're going to get very poorly absorbed commercially available estradiol and progesterone, which is called prometrium. And there's hard stops in Epic, which is the electronic medical record that most of the nation uses for primary care and all other aspects of medicine, that puts a hard stop if you try to exceed any of the commercial doses. So you're going to get a placebo dose from your PCP, and it's going to be commercially available bioidentical, which is going to give you crappy levels. So you might feel a little bit better, but you're not going to get any significant change in your outcome of like who gets heart disease, who gets cancer. And so that's what we're seeing in, I'll draw another analogy to the trades. If you have a general contractor that's renovating your house and they say, you know what, I've done some electrical work back in the day. I've also put a couple toilets in my own home. Instead of hiring a subcontractor to do your electrical and your plumbing, why don't I just do it? I can YouTube it if I get into trouble. And so that's the analogy of going to your PCP who has no hormone training or whatever they got in medical school, which is only on birth control, basically, is like having your general contractors try to do part of the job when they don't have the formal training in it or the certification.
Yeah. Okay, so one takeaway though that I am grabbing from this, as you mentioned, because there's two separate parts. There's symptom control and there's the protection piece.
Yeah.
So if somebody financially really cannot afford not having it covered by insurance, would this be an individual case of, well, like at least get on it if you're getting symptom relief so that you can get in the gym so that you can do these other things because you're feeling better. And then we can keep working towards actually getting on more of the correct dose and substance. Is that right?
The problem with it is they think that they are protected because if they've only
Mm,
seen somebody in the insurance world, they don't know any better. They'll put them on that tiny dose and never check levels. And if you do have a uterus, if you do not have adequate opposition in the uterine lining to estrogen with adequate progesterone, you can cause uterine cancer.
mm.
So a tiny little dose of progesterone, if it's not adequate to oppose the estrogen in the uterus, you could possibly be stimulating your uterine lining.
Okay.
So there's
That makes
some nuances that maybe, yeah, I would take synthetic estrogen tomorrow if that was the only thing I could get my hands on and I was in menopause. But I'd certainly prefer estradiol compounded.
mhm. You're going to either think this is funny or roll your eyes at me, but I've started sitting in on a lot of my clients' initial consults just because everyone's just so nervous. So I'm like, I don't mind. Let's just do this together. And the one thing that I have seen is individuals come in on those other forms of the estrogen and progesterone and getting to see the lab work firsthand that like you're on something, but it's not increasing your levels. Like it's really not doing much. So that was an aha, and you just described that perfectly as well.
And that's what we see too when women come to us on it. I've had a lady with breast cancer and she'd been on a commercial bioidentical product for years, but it was such a low dose, it wasn't giving her any protection. And so it's not really fair because the people prescribing it should have training in it and they don't. And nowhere in medicine would it ever be appropriate otherwise to prescribe something you have no training in.
Sure. Right. Huh. Okay. So you had mentioned your training was WorldLink Medical, correct?
Yes.
Okay, because you were so helpful to me years ago when you and I first started talking. There was always this feeling of I hear you and I don't know where to go, or I hear you and I don't know the buzzwords to
Yeah.
ask or the things to look for. And I don't know if I've told you this story yet, Nicole, but you had told me WorldLink Medical and buzzwords are things like normal's not optimal. I've had you on podcasts. So my conversation to you was I think I just need to fly and get to you because I think I just need to put all my people on an airplane. Because obviously I can't find anything around here. And then I was pulling out of Starbucks literally a mile away from my house. And I saw this sign and I was like, does that say Optimize You Hormone Clinic? So in my backyard, and then I forwarded the woman who runs the facility. I was like, can you listen to this podcast? And can you tell me who your training was through? And she came back. She's like, WorldLink Medical. And and she totally knew of you. And she was like,
It's
of
great.
course I agree with this podcast. And then where's my book? You're all over the book that I got given at this clinic. It's like Dr. Nicole Lovat. It's like, oh my gosh.
That's
Um,
awesome. Yeah.
yes, my journey has come full circle and complete. So it's been very cool. And I just need to thank you from the bottom of
Yeah.
my heart that your introduction to all of this and opening my eyes.
Good.
So you're the best. Yes. But with that said, anything else that you could tell our listeners as far as buzzwords or things to ask physicians or things to research on their own to give them, again, that confidence that you're on the right track?
Yeah, I would definitely try to focus on reading reviews that might be on Google or social media for the clinic you're looking at, and then figuring out whether you have to call or whether it's on their website where their providers were trained and the ways that they administer hormones. So, do they use wording like we optimize your levels, or do they say things like lowest dose for the shortest period of time? The preferred route of administration will depend on a patient's risk factors. So they should offer more than one route for estrogen and testosterone. And those would definitely put you in good stead of trying to find a well-trained provider. The other possibility too is if you ever called one of our clinics and we didn't serve that state, we might also know a provider that is in that state that we can refer to.
Yes, and thank you for bringing that up because individuals go through this again. Do they have to see you in person one time and then you can be virtual with them? How does that work?
So it depends on the state in which they live. Right now, everything is telemedicine until the end of the year. That law might get extended again, but it just depends on their state.
And I've also heard it's sometimes it's okay with things like estrogen and progesterone, but testosterone needs to be an in-person visit. Is that accurate?
It depends. The rule for controlled substance and telemedicine visits is currently good until the end of the year, but it might get extended again. And so right now, everything can be done by telemedicine.
Okay, okay,
Yeah.
so interesting. Anything that I'm not asking, anything you want to shout out at the moment for your clinic?
Well, we are building a new 5,000 square foot facility out in Grand Forks, North Dakota, that should open early next year. And we will be expanding services to include direct primary care, which is what we had initially thought of introducing to the community several years ago. But it's a subscription model of primary care where none of the other third parties, like insurance companies, health systems, get to weigh in on the care that's delivered. It's actually all about what the patient and the provider want. And so it's a very fulfilling way to do primary care.
Yeah, and I think the thing that the listeners need to hear, it means time. It means time with your physician,
Yeah.
right? And it's a head to toe, full body look that everything affects everything versus you're coming in for this symptom and we're going to address that symptom.
Yeah, exactly.
Okay, cool. I love that. And of course you're doing that. Like, of course, that's amazing. And
Thank you.
congrats.
Thank you.
All right. We always do this, but if you have one thing that you hope and pray that somebody heard today, if they heard nothing else, what's your one takeaway?
It isn't normal to feel terrible. So don't dismiss your symptoms and go see somebody who can help you.
You're amazing. Thank you for your time, Dr. Levitt.
No problem.